Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
We might think of being in a medical clinic or a hospital, ICU, operating room. But you know what? If we're going to fight for medicine and fight for our patients, that includes Congress.
Hello and welcome to Talking Head Pain, the podcast that confronts head pain head on.
Hi, I'm Joe Koh, Director of Education Digital Strategy at the Global Healthy Living Foundation and a migraine patient for over 20 years.
I'm joined today with Dr. Wayne Anderson. He's a neurologist with subspecialty certification in headache and pain medicine. We're going to talk about advocacy, his life passion in neurology, and what the patient community needs to know about the good work that physicians are doing on behalf of us to increase our access to treatments and procedures that help migraine patients feel better. How are you today, Dr. Anderson?
I'm doing fine, thank you.
So let's just jump right in. I noticed that in your bio and in speaking with you before the interview that you are very involved with neurology on the Hill. And many of us in the headache community are familiar with Headache on the Hill. What is neurology on the Hill and how does it complement something like Headache on the Hill?
Neurology on the Hill is very similar to Headache on the Hill, but it looks more at other neurologic topics and not just one particular disease entity. In fact, Neurology on the Hill was a model for the eventual development of Headache on the Hill. Neurology on the Hill is when a group of neurologists go to Capitol Hill and visit with our legislators and try to provide information that we think will be helpful for the field of neurology, primarily for patients.
And what's the issues that Neurology on the Hill has advocated for in the past?
There are several issues and they tend to change each year. It depends on what is going on in the community. For example, one of the major issues recently has been step edits or prior authorization processes. And sometimes we find that there might be a treatment that we would feel is appropriate for a patient, but that treatment needs to be used only after other treatments might fail. We understand that there is a cost issue and that there are maybe older treatments and maybe less costly treatments that reasonably can be tried first. But what we would like to do is we would like to be able to maybe have fewer steps. We can try one treatment, and maybe if that treatment is not acceptable for a patient because of side effects or contraindications, we then can go to the treatment that we feel would be the most appropriate. So it is a sort of a work in progress trying to reduce our step edits and obtain the best treatments for our patients, but within the scope of what we are able to do, recognizing that it is a very complex situation.
For those that aren't familiar, we all probably have experienced what Dr. Anderson is talking about. It's called step therapy and or fail first hurts, where you're forced to fail on a treatment before the one that your prescriber wants you to be on can be covered by insurance. What do you think, Dr. Anderson, that does to patients in terms of their treatment journey?
So it is a problem for patients, and it does bother the neurologists who are treating these patients because it has a bit of a setup potentially for failure. If a person were to try 3 or 4 or 5 treatments in a row and we had the sneaky suspicion that they weren't going to work, we understand that there may be a treatment coming up that might be of benefit, but it is certainly disheartening to the patient because by the time they've gone through 1 or 2 or more treatments that didn't work, their expectation and hope for successful treatment is diminishing with subsequent trials. That's one of the reasons that we really are looking towards reducing the number of steps if we can, and I think that there is a strong scientific basis for this.
I know as a patient who's experienced step therapy, it could be really demoralizing, those trial periods, having to cycle through medications that likely won't work, but it's part of the system and we all have to do it. Fortunately, I had a neurologist like you who was pretty savvy and helped me understand this is what's going to happen and here's the process. There was another issue that you mentioned that is another critical area of access, and that's prior authorizations. Can you explain to our audience what a prior authorization is and how that impacts you as a physician?
A prior authorization is perhaps somewhat of a misnomer because it doesn't really describe the situation adequately. If a physician wishes to prescribe a certain prescription medication or maybe obtain an MRI, for example, of some part of the body, We would give an authorization for that to occur by virtue of our prescription. So if you think of receiving a prescription in a doctor's office, that prescription is the doctor's authorization to do whatever the prescription says. So the word authorization is an unusual and perhaps unfortunate word in that. What the prior authorization is that in various health plans, there is a requirement to request that the health plan approve the thing that the physician had technically authorized via the prescription. So before something could be done, let's say that MRI of some body part, there would need to be somebody at the insurance company who would authorize that in addition to the physician having authorized it on the original prescription. The word prior is kind of odd because it just means that it needs to be done before the study would be paid for as one of the insurance benefits.
Are the people in the insurance companies that are making these decisions, are they specialists who deal with the issue that the provider is prescribing the treatment or study?
They can be, and sometimes they are not. I think that does depend on the company and it depends on the location. In general, I do find that the people who are performing the prior authorization process on behalf of the insurance company are physicians, and in most cases, they are in an appropriate specialty to understand what I am ordering. But I do understand that that is not necessarily a uniform experience. I might actually be lucky in that situation.
You're the provider, you have the relationship with the patient. Why are they getting in the exam room with you and saying that what you ordered is approved or not?
There are a few answers to that, and of course, the one that people always want to run to is money. And I think that that's fair to an extent. Not everything that we do as a physician is always necessary. And sometimes we do things that we really wouldn't have had to do if we had maybe approached the situation differently. And the insurance companies feel that they wouldn't necessarily wish to pay for something that they didn't think was absolutely necessary. The problem there is that ultimately I have to believe that when physicians are ordering something, we do think it is necessary. And I think that's where the conflict comes in.
Are you seeing that there is reform to this process and things that are going to make it easier for both providers and patients to get the life-saving or changing treatments that are needed?
Certainly, we are hopeful for that. I think it is a partnership. It has to look at all parties involved, all players involved, because there are, frankly, vested interests on all sides. And I think that it needs to be respected and understood, or we won't be able to necessarily move forward. One of the things that we do in our advocacy work is to try to help this situation. And if we go back to the idea of step edits, for example, one of the things is let's just say there are, I don't know, two things you have to try before the treatment that I would prefer to be used is used. So, what if the first one is contraindicated because the person's already allergic to that medication or some ingredients in the medication, and the second one has a side effect that's going to make some other medical condition worse? Well, I think that if we can explain this, then we should be able to theoretically skip right to the third step because the other two steps would be considered either unsafe at best or not very useful. So if we have three treatments in a row, for example, and we want to use the third treatment, and the patient's allergic to the first treatment, and the second one might have a side effect that would make some other condition that the person has worse, then I think we should be able to go right to the third treatment. And one of the advocacy issues is to try to allow that to happen. We have seen a sort of recognition of general cooperation because in the headache world, for example, there are guidelines as to when we move to the newer headache medications, the CGRP medications that are relatively new. And even those guidelines do indicate that it is reasonable to try, in many cases, some of the older medications that are tried and true before moving to them. So there is hopefully this idea where we can get to the medication that is best for the patient, but sooner than before, and with a better understanding and appreciation for the idea of working within the constraints of a particular system and methodology.
When you went to medical school, did you think that you were going to get so involved in policy?
No, I think when I went to medical school, I was idealistic, as I think most students in medical school are, and we were going to, so to speak, make the world a better place in terms of healthcare. Well, it turns out that if that is what our idealism is or was at the time, then advocacy for patients is a natural extension of that. We might think of being in a medical clinic or a hospital, ICU, operating room. But you know what? If we're going to fight for medicine and fight for our patients, that includes Congress.
I agree. Last question. What are you most excited about in the field of neurology?
There are so many things to be excited about in neurology. It's really hard to come up with one. But I think if there is one thing, it is the idea that we are learning more and more and more about the brain itself. We always talk about how every time we discover something new with the brain, then there's even more we didn't know. And I think this is really important for patients. We're beginning to see things that are subjectively reported that now may have objective findings behind them. It is certainly no stranger to a person, let's just say a person with migraine headache. It's no stranger to that person, anybody listening to this right now, that it's been called just a headache. And migraine is a primarily genetic neurologic disorder with multiple phases and multiple symptoms. And not every person with the disease of migraine even gets a headache. But when you take a look at the headache and you take a look at all of the rest of it, it's more than just a headache. And we didn't really have any way objectively to show this. People can also have other conditions that really don't have objective findings. Look at concussion to an extent. It is primarily what people say it is because we know that the CT scan and the standard MRI are going to be normal in a concussion. So, how do we know that these subjective complaints continue and become either a post-concussion syndrome or a lifelong migraine disorder? Well, there is emerging imaging technology and of one of many things to be excited about in neurology. And these very high definition MRIs with special additional sequences can show things that are associated with the after effects of a concussion in many cases. These special MRIs, which now are commercially available in many communities, by the way, for patients, also can show changes in the brain that are associated with a lifelong migraine disorder. There can be some changes in the thickness of the cortex. There can be some changes in white matter. There don't have to be. And some of these changes can be nonspecific, but we are beginning to see objective information for things that were primarily subjective. And perhaps that may not help us necessarily with treatment, but I do think it provides some validity to patients who have been told they only have a headache or it's all in your head or you're imagining it, because now we're beginning to see that these things are in fact real. So I think that to
That's
me is one of the most important things that's come of late.
that's really, really interesting and important, making the invisible visible, either through advocacy or through science. So it's really nice when we get validated in this very factual, matter of fact way, because as you said, Dr. Anderson, for many of us for many years, some of us who live with this disease for decades, we didn't have those advancements and people were pushed to the side and you were lucky if you found the right type of doctor to treat it. So really, really, that's super exciting to hear and appreciate that information. So if you're a patient, you can get involved in advocacy in all different ways. GHLF has a 50 state network of patient advocates. You can go to 50statenetwork.org. If you're a provider, how do providers get involved with advocacy?
In many states, and I'm in California, so it is true here, the state neurologic societies and actually general medical societies in the state have their days at the state Congress level. And also, most of the national societies, for example, for me, the American Academy of Neurology, the American Headache Society, they have their national days in Congress. And so they can be joined and a person can become involved. Sometimes it can be done virtually if people cannot travel, and sometimes it is in person, which can be a bit more convincing and a bit more compelling. And there can be a combination thereof. For example, the recent Headache on the Hill was an in person and virtual event combined.
Thank you so much, Dr. Anderson, for your time, expertise, and your passion to advocate for patients and to get your colleagues energized and excited about engaging in advocacy. It's so important.
You're very welcome. I'm happy to be here.
Thank you so much for listening to this episode of Talking Head Pain, the podcast that confronts head pain head on. If you like this episode, please give it an honest 5-star rating and subscribe so you never miss another one. I'm Joe Coe, and I will see you next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.